I'm joined today by Andrew Mangione. He's the Vice President of Government Relations for the Association of Mature American Citizens, also known as AMAC. Andrew, I saw the piece that was published by AMAC. It quotes Dan Weber, who we've had on the program a couple of times. And the topic is possible death panels coming as a result of Obamacare. This has been something we've heard about for really years around the passage and subsequent implementation of Obamacare. Let's get specific. Why do you think that this is a possibility?
A couple of reasons, David. The Independent Payment Advisory Board, first of all, it takes the Medicare decision-making process away from doctors and away from Americans' elected representatives in Congress and gives it to an unelected, unrepresentative, and unaccountable advisory board. It also jeopardizes the quality of medical treatments and services for Medicare beneficiaries, which, as you know, we're a senior organization, and a lot of our members are receiving Medicare. So we're concerned that the board will remove doctors and elected officials from the decision-making process, and the threat that poses. They're going to be charged with making sure that Medicare, the board, the members of the ipab or the Health and Human Services Secretary herself, whoever that may be, will be charged with making sure that keeping all the dollars and cents aligned with Medicare and making sure that it doesn't that it's cost effective. And
so you're talking about rationing, right? Essentially, making sure that expenditures don't go too high.
Ultimately, that it could come to that. Absolutely, in order, denying care, in order to make Medicare make sure that it remains in the black. If Congress can't do it, the ipab will step in and unilaterally make decisions on Medicare spending, which will lead to rationing. We feel will lead to rationing.
So this is, to be clear, this is your opinion of what could happen, right?
Well, the boards themselves, we're still debating this. So yeah, we're forecasting this.
Okay. Did you know that?
Look how this thing. But David, look how this thing is set up. Okay?
Well, that's what I'm trying to do. So, for example, I decided let's look at how this thing is set up because that seems to be the key thing. In the piece, which, like I said, quotes your colleague quite a bit, it doesn't seem to mention that the ipab is going to be, or not is going to be, the ipab is, the committee members are forbidden by law from proposing any changes that would affect Medicare coverage or quality, and that includes rationing care. I mean, it's in the law. So you're proposing a hypothetical that might happen, but the law already says it can't and will not.
That remains to be seen, David.
There's how can we can't say it remains to be seen because it's in the law. Right, but it's part of the law. So in other words, I could say, for example, any day now, murdering people might be legal. And then you could say to me, well, David, actually, we have pretty clear legislation. It's not legal to murder others. And then if I were to come back to you and say, well, but Andrew, that remains to be seen, I'm speaking hyperbolically and just fear-mongering, am I not?
I'm not fear-mongering, David, so don't put words in my mouth, okay?
No, I said in my hypothetical.
Obamacare grants the ipab many powers year in and year out. It's got an annual budget of more than $15 million, and it'll grow automatically each year, okay? Pretty much this board can do whatever it wants.
But where in the law, but Andrew, where in the, you're saying regardless of what the law says, the group can do whatever they want. How does, explain that? Because I honestly want to understand, because if this were true, I would be really concerned about it. So when I looked at it, the law is clear. You're saying the law is irrelevant. Regardless of the law, the group can do whatever it wants, including rationing care. How would they do that?
Let's look at Obamacare. Yeah, sure. Okay, David, let's look at Obamacare. Let's look at it. Let's look at the components. Let's look at what we were sold. Let's look at people that have lost their doctors when they were promised they could keep them. Let's look at the proposed $2,500 a year each family would save because of this great law that we're not realizing. Let's look at the delays. Let's look at the worst is yet to come with this law. Is there any reason to think that the ipab will function exactly as it's written into law based on what we know so far with the implementation of Obamacare.
Fair question. It's a fair question. It's a fair question, Andrew.
You have faith in this, David. You have faith in this law, David. We do not. We are hearing from our members, particularly those who are Medicare members, that are seeing shrinking networks. They're seeing relationships with their physicians that they've had for years blown up because the networks have shrunk. We're seeing out-of-pocket expenses rising. This is with Medicare beneficiaries. We're seeing home health care cut by $22 billion over the next 4 years to the most vulnerable segment of the Medicare population to pay for Obamacare. And you're sitting there telling me that the IPABs just, they're not going to do anything, that the law says. This law is actually working out so far. We haven't seen its full implementation because the president keeps delaying portions of it until after the midterm elections. So what we're seeing here so far with the law is that it's actually having the opposite effect, at least from an AMAC perspective. So you're questioning me as if wondering why I'm skeptical that the IPABs will not do exactly what they're doing. I think there's the proof so far with the implementation of Obamacare has shown that this law is accomplishing the opposite. Prices are going up. There's no selection in some states with regard to the healthcare exchanges.
Okay, but hold on a second, Andrew. But if I can just get a word in here, if I have to just, we're all over the map here. I mean, you're on the one hand, you're conflating delays in implementation with the IPAB doing something which would be flat out illegal. That's number one. Number two, you're also talking about issues that are related to individual states not setting up their exchanges and saying that
I'm saying that the ones that have been set up in some states aren't offering much of a choice.
Okay. The issue I'm having here.
The point that I'm making.
Yeah. What is the point? I guess that's the question.
The point that I'm making is that the law is so flawed from its fumbled, implementation on October 1st to the delays, to it not doing anything or a lot of not what was proposed.
Yeah.
In terms of savings, in terms of choice, in terms of competition, plus the negative effects on Medicare, thus far leads me to be skeptical that the IPAB will function exactly as it is written in law.
I think that's a fair concern. That's a fair concern. But to go from skepticism that something will be exactly as it is designed to there will be completely illegal so-called death panels is a pretty big jump. Let me give you another example, and then I'll of course let you comment on that. When we had the rollouts of Social Security as well as of Medicare Part D, there were similar hang-ups, mix-ups, less than ideal implementations. And again, much like we're seeing now, there was significant fear-mongering around that. And ultimately, the programs worked well. Some were instituted by more liberal individuals, some by more conservative individuals. And ultimately, we didn't have these catastrophic death panel equivalents. Sarah Palin touted the death panel myth a lot, and it was considered it was like lie of the year. And I'm seeing the same thing now. How is it different?
No. The lie of the year was you can keep your doctor if you want to. That's the lie of the year, David. Sarah Palin was making an observation, all right?
An incorrect and fear-mongering observation.
Well, I guess that remains to be seen.
No, it's already been figured out.
Let me address the Social Security and Medicare Part D examples that you gave.
Yeah.
I'm not going to argue with you that I'm sure there were bumps along the way, and I was in pharmaceuticals during the Medicare Part D rollout, and there was some snafus. However, if you look at the Medicare Part D program, it is 45% under budget over a 10-year projection because all the cost has been driven out of Part D due to generic usage. That's good for consumers.
Okay.
Social Security, and I'm not going to argue with you that Social Security didn't have some bumps and bruises along the way, but we're talking about people's health. We're talking about the cancer patient who can't see his oncologist because he was thrown out of a network due to Obamacare. He doesn't have a lot of time to wait for the bumps and the snafus to be worked out.
Agreed.
That's the big difference. You're dealing with people's lives, not money in a program that's going to compensate, or not a Social Security check. You're dealing with people's lives. So just wait for the bumps to be worked out over the next year or two. Tell that to a chronically ill person with a devastating disease like cancer or diabetes. Okay. So there's the difference right there.
I completely agree with you. I completely agree with you. I completely agree with you, Andrew. I just, however, completely disagree. Number one, that we have any evidence at all that anything resembling a death panel is going to be happening. It would be completely against the law. I agree with you, however, though, that anyone who can't get the care that they need is a problem, which is, I think, why we should be moving to universal health care, which is, of course, a totally different issue that we don't have time for today. I would encourage everybody to check out your piece and then check out a lot of the data surrounding this. I do appreciate the conversation. Andrew Mangione from the Association of Mature American Citizens. We didn't agree on everything, Andrew, but I appreciate you being here.
And I'm thank you for the opportunity to be on your show, David.